so I'm gonna do a brief presentation. What I'm gonna start with is really my experience, collaborative experience that has worked with advocates, housing providers in New York City. That has really kind of come to focusing on housing as a point of intervention to address improving the lives of individuals affected by criminal legal system, as well as a point of intervention or how I came involved or invited to be part of this as a way in which public health can help, can be part of providing skills, resources, tools to inform that advocacy and program and policy work. So let me just give this as a story, a little bit, a quick story on one of those experiences called the Fuse Project Frequent Services, frequent users services engagement that brought together. Let me find my share screen. Anyway, so housing, health, and healing. Again, advancing housing for incarceration in the public health. This image here is one that we use. It's a revolving door because we also know that unfortunately, many folks who have any entanglement with the criminal legal system end up being caught within that system, back and forth in and out of housing, but also, incarceration, but in and out of other, housing. In my case, looking at particularly homeless and housing systems. I won't go over these, but this is kind of what we all know. I think that the politics of mass incarceration really intensifies the interactive effects of multiple axes of vulnerability, exclusion, that are the same ones that we look at when we're looking at social determinants of health. Lower income persons of color, disadvantaged neighborhoods, et cetera, and as Professor Galea mentioned, Dean Galea. We also are becoming increasingly aware of higher rates of mental illness and addiction challenges among persons who are caught up in the criminal legal system, but less attention paid to chronic illness, as well as various kinds of other comorbidities. I also think that we in public health can contribute to this misguided focus on recidivism as a focus, the single axis of focus for reentry and diversion initiatives, if you will. And again, these multiple mechanisms of exclusion manifest in not just effects on the persons incarcerated, but on their families, on community members as well too, on multiple dimensions, including those that affect health. Just really, really quickly now, some stats from Prison Policy Institute. As I said, we're aware of substance use challenges, mental illness, less so about and some about infectious disease in terms of hepatitis, HIV, et cetera, but also TB, also high blood pressure, diabetes, heart-related problems, et cetera. You can see that it's substantially higher among persons incarcerated than persons who are in the general population. The most recent 2030 Healthy People 2030 had set aside a specific category of incarceration as a social determinant of health. I also want to kind of point out that incarceration increases risk for homelessness, and housing instability or homelessness increases risk for incarceration. And I won't go through all the dynamics of this, but just in terms of, well, we have a slide here. Yes, persons who are lower income, who are housing, is very, very difficult to not run into something being, a vagrancy. In New York City, theft of service, jumping the turnstile, or sneaking onto the bus, or other kind of minor crimes that really, really increased jail population. And of course, the substance-related war on drug criminals, if you will. This becomes even more challenging in areas that are changing and gentrifying because of the easy, quote unquote, quality of life or kinds of offenses. We did an initiative. We did a program. I'll tell you, this is one of the tenets. What had happened was that in New York, the advocates had noticed that they and the housing providers that they had served multiple people that had multiple episodes of jail and cycling in of homelessness and other crisis care institutions, detox, hospital inpatient, ambulance rides, et cetera, et cetera. And so Fuse was an initiative that kind of succeeded in removing restrictions from using publicly supported services, dollars to provide housing, supportive housing for individuals. And then we were brought in as the evaluators. Again, a footnote that they had done original evaluation with just using, I think, John Jay, School of Criminal Justice, criminologists, to look at matching the jail and the homeless costs, but they didn't include a health dimension, and that's what we did and where we came up. This is just the disparities that we were talking about. One of the techniques that we use, and this is when I talked about a little bit of more sophisticated technique, we looked at point in time and cumulative effect in terms of jail and services. But yes, there are multiple people that have some continuing contact with criminal justice. But if you really look at this kind of more sophisticated trajectory analysis, looking over time, over a 2-year period, what we're looking at here is that the red bars, this is the intervention and closely matched comparison group. The red bars are those that times, months that are persons incarcerated. The blue is if they're in a homeless shelter. Green is when both, or white is neither. And just really quickly, each of them had on median 7 incarcerations and homeless shelter admissions in the prior 5 years. In this 2 years, we had 85% had none or one limited episode of incarceration, no shelter over time. Again, I don't have time to go into the details of it, but I just want to have some evidence that it also saved a lot of money. I personally think that saving money, as opposed to having an impact on health, quality of life for individuals, families, and communities, but that's what, of course, gets the public attention of policymakers often. There was substantial savings, cost savings, and it basically more than paid for the intervention itself. What I want to say now is that this is now been implemented in multiple jurisdictions and currently being used for the local closed Rikers effort. Closing Rikers, our local jail. Probably most people know about Rikers Island as one of the most challenging and pleasant jails and mechanisms of carceral punishment and limitations. Anyway, the notion is that looking at the health data and the mental health data, kind of advocates coming to an estimate of there are about 3,000 individuals who are homeless, and that the need of over 2,500 individuals that would need or benefit from supportive housing, using the research from what we've done before in terms of likelihood of recidivation, benefits in terms of health and healthcare expenditures. Basically, the argument is that it would save $1.2 billion less incarcerating the same, providing supportive housing, or at least addressing housing barriers compared to continuing to incarcerate these people. So the argument is that, again, part of the plan here locally to decarcerate, to close Rikers, and to change the response to especially these kind of low-level quality of life substance abuse issues, is to work to provide and pay for more housing, and we have the money to pay for it, or at least we have arguments that they can be paid for. And that's it, and I'm going to stop now because I don't want to take more than my 8 minutes. Thank you very much.